Welcome to Session 1 of Sleep Academy. If you haven't done so already, please view the introductory video. And if you've done so, let's go ahead and get started. Just to remind you, this is a 10-session program, and I would suggest that you take these in order since we are basically building the program so that the sessions each require mastering the material from the session prior. So the learning objectives for Session 1. First of all, we're going to be reviewing the fundamentals of normal sleep in Part A. In Part B, we're going to be developing an approach to getting organized and getting the overview of the history for a new sleep patient. And in Part C, we're going to be applying these early lessons to treating 3 common cases. So without further ado, let's take a look at the fundamentals of Session 1. In reviewing normal sleep, I'm actually going to be taking what would probably be about 300 or 400 pages out of the sleep medicine fundamental textbook and give you what I think is the essence. And I'm going to start out by giving you information from the viewpoints of sleep that include how sleep is staged. And yes, some of the neurophysiology. It will be important for understanding disorders of sleep and understanding treatment. We're also going to look at circadian factors briefly in this section with an entire section that will be devoted to the abnormalities in circadian rhythms. And we'll talk about homeostasis, which is basically the regulation of our sleep drive based on the amount of sleep that we have or have not gotten. The value of sleep is usually assessed in terms of looking at what happens when one is deprived of sleep. So we're going to do an overview of sleep deprivation and its consequences as well. So let's take a look at a clinical definition of sleep. This is a reversible behavioral state during which we have no perception of or responsiveness to our environment. So we're disengaged from our environment. And more importantly, I think over the last 10 years, we're learning more and more about the physiologic recovery of the brain and the body that occurs from the stresses that are developed during the preceding period of wakefulness. So let me introduce you to the basics of sleep staging. And back in the 1960s, Restrictive and Kales were credited for defining stages of sleep. And the definition was an EEG definition. The electroencephalogram, basically the waveform that one measures when looking at the electrical activity between 2 scalp electrodes. And the changes in the waveform between wakefulness and as we enter sleep, you can get a general appreciation that the frequency of the waveform drops a little bit as we go to sleep. And also there's the development of higher amplitude as well as slower waveforms. And we're going to look at a minute at these actual stages. But I think you can appreciate from this the differences between stages and particularly how different they are from wakefulness. Now, a typical distribution of the stages are reflected on the right side of this page on this diagram known as a hypnogram. And in this particular depiction, you will see that there are maybe 4 to 5 cycles that one might attain through an 8-hour period of sleep. And so this, during the 8-hour period, you will notice that on the x-axis of the number of hours, and you will see that in this cycle here that the end of the cycle will end in stage N3 sleep. And the same for the second cycle. And then the cycles that are in the latter part of the night will end up with rapid eye movement sleep. And so the rapid eye movement sleep is something that is going to be more prevalent in the second half of the night and a bit more in each of those cycles toward the end of the night. So each of these 4 to 5 cycles would generally be 80 to 120 minutes, and that would be a very typical representation of what we might consider normal as far as the distribution. So let's take a closer look at some of these stages. Now, although defined initially by the EEG, we're also going to talk about some of the unique physiologic and clinical features of each stage. It's important to note that in the transition from wakefulness to stage 1 sleep, that there around this point would be a high frequency waveform that becomes slower. And this would be the onset of sleep or stage 1 sleep in approximately this area. We define it therefore as a low voltage mixed frequency stage. It is a light stage of sleep that one can be generally fairly easily awakened from, and it only lasts several minutes. In most situations, 1 to 5 minutes, and that's it for stage 1. Stage 2 sleep has some very unique EEG characteristics. First of all, there's these clusters of waveform known as sleep spindles. There also are these periods of high amplitude, low frequency waves known as K-complexes. And these are generally what defines the EEG of stage 2. We also spend half or more of our time while asleep in stage 2. There's an increase in cerebral blood flow. There's also an increase in carbon dioxide because of some hypoventilation. Our breathing slows down as we enter stage 2. There is a reduction in our blood pressure, our heart rate. The heart is slowing down and resting. The oxygen saturation drops 1, 2, or 3%. In general, the metabolic demands, the metabolic activity of the brain are reducing during the stage. And that's measured by studies such as PET scanning, where we can see the drop in metabolic activity. We also know that there is a role clinically in memory consolidation and also in recovery of the neurons throughout the entire brain. So when sleep stages were first defined, there was actually a stage 3 and a stage 4, and they both were characterized by having slow wave activity. 3 didn't have as much as 4, but in 2008, the American Academy recommended that N3 be one stage as what was initially represented as 3 and 4. You will notice that in the waveform that we basically have a very high amplitude, slow frequency wave. These are known as delta waves or slow waves. These represent the synchronous activity between the neurons of the hypothalamus and the cerebral cortex. So this is deep sleep. It's also known to some as delta wave or slow wave sleep. It occurs primarily in the first third of the night, with those first 2 or 3 cycles comprising what most of N3 is represented. It is felt to be the most restorative stage of sleep. And this is supported by the fact that when we're sleep deprived and tired, that this is where most of our rebound of sleep occurs with more stage N3. There's also a protective effect. If you look at a sleep study in somebody with sleep apnea, that they will be snoring once they enter N3, but generally there's actually an improvement in apneas during this stage of sleep. Unfortunately, with all the good things that happen with stage N3, it declines as we get older. There's less of it that we have every night. So stages 1, 2, and N3 are collectively known as non-REM sleep and different in many ways from rapid eye movement sleep. As we take a look at REM sleep, there are some clear unique features, and the first is that the EEG has what some consider to be a sawtooth appearance. If you've got a good imagination, I think you can go with this and say that it kind of looks like the edge of a blade of a saw. The EMG is the muscle activity, and that activity during REM sleep is quite unique in that there is a dramatic, almost a paralysis of the muscles, a dramatic reduction in muscle activity in all the skeletal muscles. So the diaphragm is still intact as far as activity. The eyes are moving rapidly, but otherwise almost all of the muscles are essentially paralyzed. So during REM sleep, the paralysis of the tongue may make obstructive apnea worse. The paralysis of the accessory muscles of breathing may make breathing worse for a COPD patient, for instance. When they enter REM sleep, typically their oxygen levels drop dramatically with the lack of effort of the muscles of the intercostals and the neck in the COPD patient. So the EMG then will show the rapid eyes, and otherwise not much going on in those other muscles except for the diaphragm. We dream during REM. We also have a lot of activity in the brain during REM. The limbic system throughout the thalamus is very active. There is some role for emotional recovery, and there's also felt to be a role for increasing our creativity the following day based on what we've done in REM sleep. So let's talk a little bit about neurophysiology of sleep. In the last 30 years, we've learned a lot about this. There's going to be two slides. The first one here will be pertaining to wakefulness, what we know about it, and then the second one will be pertaining to sleep. So the wakefulness pathway, also known as the excitatory pathway, is one where we have release of cholinergic activity throughout the entire brain, promoting wakefulness. There is the supporting cast of these neurons that secrete aminergic activity, and from top to bottom they are histamine, dopamine, serotonin, and norepinephrine. They all support us being awake and alert, and the activity of this is basically very focused in these areas known as nuclei, where the neuropeptides are generated and secreted. There's also a substance known as orexin or hypocretin, and this is a neurotransmitter that was identified in the 1990s. We know that the condition known as narcolepsy is associated with a genetic deficiency of this neurotransmitter. To round this off then, glutamate is a neuropeptide very important in maintaining wakefulness, widely distributed throughout the brain. Finally, if all those things aren't working well enough, we can have sympathetic activity from below, the ascending reticular activating system. We can be wide awake simply from getting activity from the adrenal gland, whether it's visceral or somatic stimulation. It can make us awaken despite the other things not working all that well. Now, may look a little complicated here. We'll talk a little bit about more in the pharmacology section, but consider a few things at this point. Starting from the top and working down, the medicines, and there's dozens of medicines patients are on. Up top, cholinergic activity. So anticholinergic medications will cause drowsiness. Moving down, histamine. Antihistamines will cause drowsiness. Dopamine is a site of activity that is often used for the stimulating medications such as amphetamines and modafinil. Serotonin and norepinephrine are both very important because many medicines will increase levels of this by reducing the reuptake. So we have the serotonin reuptake inhibitors, the SSRIs, the SNRIs, or the slow norepinephrine reuptake inhibitors, and those medications, yes, they can improve mood, but they can also cause wakefulness in undesired situations. Orexin, many of you may be familiar with Belsomra. That's a medication that is used as a blocker of the receptors for this. That is the mechanism for it being a hypnotic medication. So a few of the pharmacologic considerations to at least understand up front. Let's talk a little bit about the neurophysiology of sleep. And this all starts with darkness. And so with darkness, there is a message sent to the retina. And then behind the eye, the retinothalamic tract, sending a message to the biologic clock, the suprachiasmatic nucleus. And with this, we're turning on the initial process of sleep. And that is, first of all, telling the pineal gland to secrete melatonin. Melatonin is a hormone that is distributed throughout the brain and the entire body. It has a role in many circadian functions and also has a role in telling the hypothalamus to start stage 2 sleep. And stage 2 sleep is basically characterized by that area of the hypothalamus, known as the VLPO, secreting gamma-aminobutyric acid, or GABA, also facilitating the secretion of adenosine, another sleep-inducing neuropeptide. So as the stage of REM develops, there is a signal that is a cholinergic signal up to the limbic system, and simultaneously there is a signal down the spinal cord saying we are in REM sleep, we are dreaming, do not move. It basically is sending a message to the spinal cord to inhibit motor activity. So let's consider a few pharmacologic things here. First of all, melatonin, widely used in regulating circadian functions. Also, in some situations, it can be helpful in terms of inducing sleep. Melatonin receptor binders, such as rosarum, are sometimes used as a hypnotic. But most of the hypnotics are focusing on the site of GABA. So GABA is basically where benzodiazepines will work at those receptor sites. Also, all of the Z hypnotics, including zaloplan, zolpidem, and azopiclone. So a very important pharmacologic site, and unfortunately it's a problem that many patients have been on GABA-related medications and come to us because problems have developed. So that's a very important mechanism to be aware of. Adenosine is an important neuropeptide because this is the site where caffeine will bind and inhibit sleep, and it's obviously a very commonly used stimulant medication. So those are a few of the pharmacologic considerations throughout this pathway. So the scientific viewpoint we're going to take on next is the circadian one. And this is basically considering that the suprachiasmatic nucleus and melatonin regulate wakefulness and sleep, that this is basically a viewpoint that tells us when those factors are in effect. And so the depiction here in this graph is that on the y-axis, this is the maximal amount of wakefulness, so you're 100% wakeful. Generally, we get up in the morning, we're something close to 100%. And then the x-axis is the time of the day. So starting out then in the morning, we will basically at 6 o'clock be drifting down this slippery slide until around afternoon. Our level of wakefulness will drop in this little plateau here. Many societies recommend or recognize that a siesta is a good idea at that time. And there is always going to be a rebound to some degree through the evening hours, and then a drop off until the nighttime when most of us are sleeping. There's then an increase in wakefulness in the early morning hours as we start to prepare to awaken. So consider that if you're driving on the Beltway at 2 or 3 in the afternoon, that no surprise that traffic accidents are doubled in prevalence over other times of the day. Consider also that if you're a shift worker, let's say a nurse in the ICU, how much less your wakefulness will be at that particular time unless you've adapted and adjusted your circadian rhythm over months or years. So this is basically a summary of process C. With a general understanding of process C, I'm now going to introduce a process that somewhat opposes this, and this is called process S, or sleep homeostasis. And this is a a mechanism of regulating sleep intensity as well as sleep duration. In summary, the deficit of sleep will increase our sleep drive or increase process S, and the repletion of sleep will reduce the sleep propensity by satisfying process S. So process S is basically going to, in addition to process C, generate what we know as a two-process model. And some of the visuals for this are similar to this one by Borbely, where we basically will be looking at the two processes opposing each other. So the circadian alerting signal is one where we have more and more alerting process regulated by our biologic clock and the suprachiasmatic nucleus. The opposing force is process S, or the sleep drive, which is basically going to change based upon how much sleep we've had and how much sleep debt we have. So the net then will be our alerting signal, and generally around the time that it's nighttime, that alerting signal will drop, and we will be reducing the sleep load, and this is basically going to create something similar to the following graph as far as the summary of what results. So the regulation of the two-process model then, the net of this is something that could be looked at in this fashion. The process of the circadian rhythm we've looked at as far as how it proceeds in terms of our level of wakefulness throughout 24 hours. Again, we have on axis Y the degree of maximal wakefulness, and then on axis X the time of the day. So process S then will basically, if we have a significant sleep drive, will be dropping our level of wakefulness, and it's not going to be linear, but there will clearly be a reduction in the wakefulness level based upon how much sleep deprivation, how much process S is playing a role. So consider now, if you're somebody driving on the Beltway, how much worse it will be if you didn't sleep the night before. And also consider if you're taking care of a patient in the ICU at 3 o'clock in the morning and you didn't sleep for 24 hours, how much less vigilant you're going to be based on the impact of both of those conditions together, process C and process S. So we're going to move now from the scientific viewpoints of sleep into some clinical information, and we'll be exploring the impact of sleep deprivation. Common topic, because it's usually assumed that this is one of the best methods we have of looking at the value of sleep. We'll explore the impact on immunology, the cognitive function, the performance impact from sleep deprivation, changes in sleep-linked hormones, and the associated disease states and mortality with sleep deprivation. There clearly is an immunologic consequence to sleep deprivation. So when your mother said you've got to get more sleep, you're going to get sick, she was absolutely right. We do know that when animals such as rats are deprived of sleep, that they will generally die within 5 to 7 days from spontaneous bacteremia. We don't have that data in humans, although money-desperate residents will certainly deprive themselves and have other things measured, and we can see that after 48 hours there's a reduction in lymphocytes, cytokines, and antibody response, as well as killer T cell levels. So definite impact in those respects. The consequences in terms of cognitive dysfunction are pretty well recognized. We have many studies that show reduced recall, poor decisions, a lot of data out there regarding the link between sleep deprivation and depression, as well as other mental health disorders. There's a hallmark case in 1984, the Libby Zion case, and this is an important one to know. An 18-year-old woman presented to an emergency room in a New York City hospital at that time. And she died in several hours because of an error made by a resident who had been essentially up for 24, 36 hours. Her father pursued this and actually found out that the error was made because of sleep deprivation, and this led to a grand jury case and decisions that have had implication in terms of the graduate medical education group. So now there are sleep requirements for medical residents, and this has spun off into many other areas of medical professionals as well. We also know in terms of cognitive dysfunction, just in the last year, there was actually studies noting the increased deposition of beta amyloid. This was noted throughout the brains of animals, and also markers for this showed human results as well. And this is basically the substance that, when increased, will lead to the plaques that we see in Alzheimer's disease. So similarly, there's a great deal of data supporting that the consequence of sleep deprivation significantly impairs performance in several different levels, generally in more complex skills particularly. And this could be delays or errors in motor skills. Surgeons basically have reduced hand-eye coordination that has been measured. Anesthesiologists take longer to intubate. Professional athletes, there's generally a threefold increase in reaction time. So not just an impact on performance, but also on increased injury rates in these athletes. So sleep deprivation also has significant impact on several hormones, and some are sleep-linked hormones, and in other words, they're directly related to certain stages of sleep. And with the reduction of these particular hormones, growth hormone is quite significant because it is secreted predominantly during slow wave sleep. So kids that don't sleep well certainly of significant impact potentially. The other hormones then can be reduced, including TSH, prolactin, and luteinizing hormone, all from the pituitary. Leptin is also decreased, and this is basically the hormone of energy utilization, and so it will basically reduce the amount of fat that is burned. There's also an increase in this hormone known as ghrelin, and this is the hormone of satiety. So as this increases, our hunger goes up, and so therefore being sleep deprived generally will make us eat more. And so if we looked at the combination of ghrelin increasing our appetite and leptin reducing our fuel utilization, then there's an obvious risk here that increasing weight and developing obesity is going to be a consequence of sleep deprivation. So probably the most impressive endpoint about sleep deprivation consequences is that it is associated with an increase in mortality. And in this study by Wingard, published in 1983, and in several studies published internationally, including Japan, very similar results. And what is noted is the groups that sleep for less than 6 hours versus those that sleep 7 to 8 versus those that sleep over 9 hours. If you look on the y-axis, the percent who died over the next 9 years in the study, large populations, revealed that the sleeping less than 6 hour group had a clear increase in mortality, women as well as men, compared to the 7-8 hour group. And also an observation in this, as well as the other studies from other publications, are that if one sleeps more than 9 hours, there's actually a slight increase in mortality there as well. So this is called the classic U curve of mortality associated with sleep duration. It's not quite as clear why greater amounts of sleep are associated with increased mortality, except many believe that it's because there are sicker populations that are requiring longer periods. But there's an interesting condition. It's a rare condition that kind of makes the case as well. And if not, at least it's an interesting example, and it's called fatal familial insomnia. And it's a rare genetic condition where there is, in midlife, a degeneration of the thalamus, where these patients are they become unable to initiate sleep. So they have this insomnia, and they die within 8 to 16 months. And so an interesting correlation. We don't know why they die, but certainly a vivid example of a condition where not sleeping enough is associated with a higher mortality. So understanding why there's a higher mortality associated with sleep deprivation, one way to kind of justify the correlation is to show that there's an increased prevalence of conditions that can lead to death or at least morbidity. So the three that are clearly associated with sleep deprivation are obesity, and we talked about mechanisms in terms of the hormonal explanation, cardiovascular disease, and diabetes. There's also a less statistically convincing association with stroke, malignancy, and sepsis that have higher prevalence among patients who are sleep deprived as well. So, having shared some data that clearly shows that sleep deprivation has some horrible consequences, it's equally distressing that it's such a common problem. And the National Sleep Foundation, based upon the data that I've just shared with you, recommends 7 to 9 hours per night of sleep. Now, if we look back 80 to 100 years ago at sleep averages in the U.S., it was close to 8.5, 9 hours. And in the past 5 years, the averages are more in the range of 6.9 hours. So there's clearly no information that shows that our physiologic requirements of sleep have dropped 2 hours a night over the past 80 to 100 years. So sleep debt is very common, has to be considered in all patients that come in drowsy, fatigued, and important to be able to educate patients of why it's so important to get adequate quantities. So with that, we are going to end. This is part A, and I understand you can certainly go ahead and take a break for now, and then we'll wait for you to come back and start part B.